All right, and it looks like we are live. Thank you so much for joining us. My name is Dr. Chad Kuntz. I will be your host tonight. I am a sports physical therapist. I'm the owner of Prime Movement. And tonight we're going to be walking you through the big question, is it possible to get your shoulder back to 100% without corticosteroids, medications, or surgery? Again, thank you for being with us. I don't anticipate this to be too long, but I do want to be thorough. I do want to make sure that we answer all of your questions, and let's go ahead and get started. So guys, again, we're here to answer the big question. Is it possible to get your shoulder back to 100%, truly 100%? I've asked some of my clients this time sometimes, and I go, are you close to 100%? And they go, well, I'll never truly get back to 100%. So they'll kind of change the scale. They'll be like, well, now I'm my new 100%. And I'm going, no. What do you really want to get back to? What would truly be 100% for you? Maybe it's rock climbing. Maybe it's playing full 18 holes of golf. Maybe it's playing 3 hours of tennis. Maybe it's picking up your grandchildren overhead. Whatever that is, that's what we're here to help you get back to. We don't want to be falling back onto a new scale of 100%. And a lot of times people don't want to take corticosteroids. They don't want to take opioids and muscle relaxers and these big, strong anti-inflammatory medications because it's bad for the gut. Well, they certainly don't want surgery, a rotator cuff surgery or what have you. My name is Dr. Chad Kuntz. I'm board certified in orthopedics and sports. I'm a strength and conditioning specialist, guys. And like I said, I'm the owner. And most importantly, I've helped hundreds, if not thousands of people get back to 100% without medications, injections, surgery. And I'm really, guys, quite honestly, I'm here to tell you how we're doing it, okay? So first and foremost, before we get started, I'm kind of curious where you are right now. Where are you from? From those that are tuning in, just type your name and where you live, and right now in the chat. Ken, thanks so much. Looks like you're from Fort Mill. We've got Susan here from the Ballantyne area, and a lot of other people are filling in right now, which is fantastic. Really, this is more than I could have ever hoped for. It looks like we're sitting around 300, 310, and it's climbing pretty fast. So a few people are just rolling in late, which is totally fine. But it's great. It looks like a lot of people are right around the Charlotte, Fort Mill, Ballantyne area. A few of you are even from Uptown, so that's great. Okay, thank you guys so much for being here. Let's see. If you are currently suffering from some type of shoulder pain, for those of you that are live right now, discomfort or ache, just type me in the chat. Or you can have fun and use this emoji right here. Me. Woo! Yes. Okay, and it makes sense, right? You guys are here because you want to know, really, what does it take to get to your shoulder 100% without, all three of those things. So fantastic. I'm really glad you guys are here. I want to kind of get into the game plan today. I want to really drip into the most common diagnoses that are most likely causing your pain. I'd like to discuss the truth why your shoulder still hurts, even if you've seen a chiropractor or have been seeing a chiropractor, a massage therapist, or heck, a physical therapist. We tend to find our clientele have tried, quote-unquote, physical therapy, which I kind of get frustrated when I hear about that, because that means you saw a physical therapist, you saw a human being. That would kind of like be saying you tried doctor. You didn't try a doctor, you saw a doctor. So people have seen a physical therapist before. A lot of times they've seen many physical therapists for many years, and they felt like they never got better. And what do you guys need to get back to 100%? There is a bonus at the end if you guys stick around. All right. As promised, the most common diagnosis that you guys have been diagnosed with that may be causing your ailments or pain. In this, I'd like to kind of review the rotator cuff as well, exactly what that is. I'd like to review the parascapular muscles or the shoulder blade muscles. You're going to want to know about those. And we're also going to actually review the thoracic spine. I'd like to use this anatomy model here, this kind of live dynamic variation, so that you guys can have a better idea of kind of what we're talking about here. So let's go ahead and get started. I'm going to zoom in, and this is just kind of looking at your left shoulder from the side here. And look at just relationship, from that glenoid to that shoulder. The glenoid is really small compared to the head of the humerus here. And then you've got your shoulder blade that kind of wraps in around it, right? And the shoulder blade is on top. A lot of times people who have had ongoing shoulder pain, instead of their humerus sitting kind of right where it needs to, let me go ahead and kind of draw this out for you. it tends to sit more forwards. All right, so you can see how I'm drawing it out there, how the the shoulder is now sitting forwards by a few centimeters almost. And then sometimes people have problems because their shoulder, so to speak, isn't kind of sitting in the middle, but it's sitting more posteriorly. So I tend to find that getting that shoulder to sit right in the middle, kind of like a golf ball on a golf tee, is very, very helpful. Now there are 4 rotator cuff muscles. There's the supraspinatus. There is the infraspinatus. Here is the teres minor. And then we'll flip it around, look on the inside of the on the inside, and that is, I gave it away, the subscapularis. That particular muscle is included for internal rotation, all right, whereas the others are most likely external rotation. All right, the pecs too, for those of you that sit at the office and you've got bad posture, you've got forward shoulders, the pecs, the traps, and the deltoids, and I'll go ahead and highlight those here. All of these areas in my clients who have really kind of chronic and achy shoulders and painful shoulders, they have really tight trigger points and knots and tightnesses in these 3 areas, especially where I'm marking right there in the upper trap. Or those of you maybe who shrug your shoulders, maybe some of you know when you get stressed you kind of shrug your shoulders as well. And all those are quite honestly problems. And then I did want to kind of briefly go through the parascapular muscles or the shoulder blade muscles. All right, some of you have tightnesses back here where I'm highlighting. Those are your rhomboids. And then some of you even have tightnesses up here, kind of the base of the neck, which almost feels like shoulder and neck. You're not quite sure. But listen, ladies and gentlemen, the levator scap and these rhomboid muscles here, they cause so many problems for my clients with shoulder pain. They're often too tight or they're often overutilized. So what I tend to try to do is release those muscles and try to get these muscles like the lower traps. I'm not sure if you've heard of the lower traps or not, but the lower traps are a really important muscle that sit right there that helps stabilize and move your shoulder blade the appropriate location, appropriate movement. I'm highlighting here the lats. The lats are a really big, broad muscle, and look at that. Look how it wraps all the way up and inserts itself just on the humerus right there. And that is, again, one of those just poor postural muscles that gets really tight on my clients, and it actually pulls the shoulder forward like I kind of drew on it earlier. And then a muscle that most of you probably haven't heard of that you need to know about is the serratus anterior. And look how it sits on the rib cage. And I'd like to just show you the motion here real quick, because a lot of you have been taught to really squeeze your shoulder blades down and back, right? Squeeze your shoulder blades down and back. But the reality is I find a lot of success in going the opposite direction. Do you see that movement right there? I find a lot of success in getting the shoulder blade to kind of go up and out, particularly with overhead movement. And that's exactly what the serratus anterior muscle does. And it tends to just be incredibly actually relieving and alleviating for those who have shoulder pain and or any type of neck pain, okay? So I wanted to just kind of walk through that just to kind of give you guys a little bit of an idea anatomically of what we're dealing with, okay? So some of the key points that we just went into there. First one would be the shoulder position. The golf ball on the golf tee is analogous to what your shoulder joint really is. The humerus is kind of like this big golf ball, and the glenoid is kind of like this small tee. In fact, this isn't exactly proportionate, but you get the idea. The tee is about 30% the size. That's right, 30% of the size as the shoulder joint. That humerus doesn't have much to rest on. And in fact, the whole purpose of what we try to do is to get your shoulder joint to rest appropriately right in the middle of that tee. If it's too far on the lip, if it's too far on either lip, most likely you're not going to have a happy shoulder joint, okay? And then in addition to that, the thoracic spine, which sits right here, has to have good extension. So a lot of you tend to slouch forwards, round forwards. You sit at the office all day, you get consumed by getting into your computer, or maybe just haven't always really had good posture. You're getting older, you're losing that postural touch. So we need really good extension, and the shoulder blades have to be in a appropriate position too. And then I want to show you a little bit of information about the supraspinatus. That's one of the 4 rotator cuff muscles, and there's something that you need to know about it. So kind of just reviewing the key point number 1, it's kind of a red, yellow, green system that we need to keep in mind. The humeral head completely out of position. Now, in medical terms, in all fairness, that's really a dislocation. So hopefully none of you are walking out here with a dislocated shoulder, but to give you an idea that it can happen like that. Most of you who are having pain in the shoulder are dealing with some form of a humeral head on the lip, so that golf ball is not quite sitting right where it needs to be. In my experience, having worked with hundreds to thousands of people with shoulder pain, their shoulders were rounded forward, right? We're always on our computer. I'm always reaching forward. I'm reaching to grab my purse. I'm reaching to grab my coffee or whatever it may be. And we're not aware of it. Maybe even up until now when I'm just bringing this about. Maybe that you're sitting there right now, you should really kind of look at yourself and think, is my posture really what it needs to be? Or am I kind of slouched and kind of squinting in at my computer to try to see what's going on here? Or heck, even with our phones, right? Phones, wow, they've really changed everything, but something they've changed in a bad way is really our posture. And then lastly, what's great, what's ideal? The humeral head sitting perfectly in the joint. Of course, that's what we're looking for, right? And I wanted to kind of go through some of this because I think this will resonate for you. And it looks like we're still well over 320 people hanging around right now. So I really appreciate you guys being here right now. And it tells me that what you guys are getting right now is valuable. So that's fantastic. The second key point I want to go over is the shoulder blade and the thoracic spine. So how about this one? So a lot of people, a lot of you are shrugging, and we call this scapular elevation, but look how his kind of shoulders are up towards his ears. A lot of times you'll sleep and your shoulders will be way up towards your ears. Or how about when you just get stressed, right? You get stressed, you start to pull up your shoulders towards your ears, and that can be very problematic too. Now this one usually surprises people, and this is where a lot of people are like, oh my God, that's me. Believe it or not, a lot of people are in pain trying to practice good posture. I bet most of you would say, that guy looks like he has good posture, at least the idea of it, right? Shoulder blades down and back, squeeze them together. But as I showed you a little earlier on the anatomical model, it's not what we're looking for. I tend to find a lot of value in getting the shoulder blades, at least particularly with movement as you're reaching up and out. Let the shoulder blades come up and out. Don't try to squeeze too hard together. Muscles like your rhomboids and your levator scap that kind of sit in the back here are overworked. And your shoulder joint doesn't get to move freely. There needs to be some level of freedom of motion. And guys, we do need a flexible upper spine. And what I don't mean is the guy on the right here. I mean the guy on the left. So right now I want you guys to all try this. If I really slouch, if I try to raise my arms up as high as I can go, I know you can't see all of me, but that's about as high as I can reach my arms up. Now, if you guys sit up really nice and tall and practice good posture, I can almost guarantee you'll have a lot more range of motion. And that, the only thing we change right there is your thoracic spine position and your posture. A little fun fact, you need about 13 degrees of extension through your thoracic spine to have full clearance in your ball and socket joint in the shoulder. A lot of you aren't having that nowadays, and a lot of us are falling into this bad slump posture, and we need to really change that first. This was the fun fact and something you need to know about the supraspinatus teres. So just to kind of give you an idea, this is a percentage, this graph is a percentage of asymptomatic tears in an everyday normal population, 60 or older. So I know it's a little bit older than maybe most of you. Most of you are probably 40s or 50s. I'm sure some of you are 60s here too, and older. But here's the fun fact. So 72% of people did not have a tear when they went on an MRI. 28% of them did. So 30 out of, let's say, 100 people went into that MRI in that research study, and they actually found that they have a tear to their supraspinatus. That's the most commonly torn rotator cuff muscle. And guess what? They didn't even know it. They didn't even have any shoulder pain. They didn't have any problems. That's really just what asymptomatic means. Yet they had a tear, okay? In other words, guys, don't let an MRI be the only reason you move forwards with surgery. We need to have a lot more data, all right, but besides just a static MRI. We're neurological, dynamic beings. We're not just a static image from an MRI, so I can't emphasize that enough. The truth, we are moving onwards and forwards, guys. So let's get right into it. let's get right into why you still have pain, even if you've seen a lot of really qualified health and fitness professionals. My personal opinion, unless each and every one of these has been diligently sorted through, you are leaving your pain up to chance. And so there's kind of a checklist that I wanted to walk you through. Have you thought about this? Have you thought about, before even tonight, your posture? All right. Have you really assessed or been assessed with the quality of your range of motion? Has it been kind of picked apart and teased apart? Have you had isolated muscle testing? Do you know if your supraspinatus is strong or weak or painful? How about your infraspinatus or any of the 4 rotator cuff muscles or any of the muscles around it, like the biceps, the delts, the traps? Have we tested those? Because that's a huge player to keeping that golf ball in the center of the golf tee. It's kind of like a tug of rope. That's a lot of what I do. You could kind of think about this simplistically. Does A equal B? Do the front of your muscles on your shoulder match the back? A lot of you, A would be stronger than B, where your muscles are pulling it forwards. Have you had your joint quality analyzed, truly analyzed and assessed? We talked a little bit about postural assessment. This is kind of what we're looking at. There's a lot of ways to kind of screw up your posture, to be quite frank with you. What we really want to practice is good posture. It's not everything, and it's not just when standing. It's when sitting, it's when reaching for your coffee, it's dynamic movement, so on and so forth. Now, I mentioned qualitative range of motion, and I'm sure some of you are like, what the heck is that guy talking about? This is something that I think is a must, and I wanted to just give you an example. This was a gentleman who was nice enough to kind of let us utilize this. And this is just an example of kind of what a qualitative assessment would look like. Before I draw on this, I want you to think about what you see. Do you see anything just with this initial posture? I'm going to draw on this in a second to show you what I see. I see a downwardly rotated left shoulder blade and a normalized right shoulder blade. Which area do you think he has pain, left or right? Go ahead and type it in. Left, left, left. Good. I'm getting a lot of lefts, and there's still well over 300 of you here. Thank you so much for that feedback. Yes, it says left side. You can see it's depressed. It's downwardly rotated. And we wouldn't capture this until we really slow things down. I'm not a miracle worker. I'm not a genie. But I need to analyze things and slow things down so we can clearly see it. I want to see what your shoulder blade does at full overhead range of motion. I even like to look at your creases in the deltoid and trap area to see if those are symmetrical. His obviously weren't. I want to see spacing between your shoulder and your neck. Are you kind of squeezed and scrunched together? And I want to see that with a few different repetitions, and even with some weight we can add on to it. Do you guys see anything here? How about right there? Look at that. Huh? Look at how his left shoulder blade is downwardly rotating, and look at the size of that medial spine. Much, much different. You think there are problems there? Absolutely, ladies and gentlemen. We absolutely saw something there from his shoulder blade, and keep in mind that's just one way of kind of going into it. We all should be qualitatively assessed like that. If you're not, I think we're leaving it up to chance. In addition to that, daily habits. What are your sleeping positions like? You know, who taught you how to sleep? How about that fun question? No one really. You probably started when you were about a month old, and you've carried on until now. Right? Until you really found out there's a problem. We need to address sleeping positions, how you're driving. A lot of my clients that have shoulder pain are hunched way up there. Or heck, even carrying a backpack or purse. How are we doing that? What's the quality of that look like? What's your unique list of injuries or surgeries? Everyone should be not created or not treated the same. We need to be basing that upon your previous injuries or surgeries. What are your previous sports? A lot of you have had high school injuries, right? Which are kind of coming back to haunt us as we get a little older. Nutrition recovery. I've actually done a few different podcasts with dietitians. We talk about the importance of nutrition with the recovery process. And what's your overall fitness level, right? So if someone's been training for 10 years versus if you're new and just having shoulder pain, you guys need to be treated much differently. These are examples of sleeping positions. I thought this was a great animation. I will tell you, like right here, that's not a good position where your arms are up over your head. That can actually cause them to get ischemic. They can lack blood flow. Or if it's smushed underneath you, like this guy on the top right, He's smushed his left arm underneath there, and that can cause a lack of blood flow in the area, and that can cause some significant problems. And who you are matters. If you have a right labral tear in your shoulder, you've had neck surgery, versus someone that comes in, they've had no surgeries and tennis, you're going to be treated much, much differently. I'm going to be a little bit more careful with someone over here like that. They might be a little more sensitive to movement, or they might fear movement a little bit more. Whereas someone over here who's been athletic most of their life, they've been playing tennis all their life, they've got no surgeries, they should be treated accordingly. All right, fantastic. If you have any questions, just please keep putting them in the comments like you have been. I probably won't be able to get it during this kind of online presentation right now, but I'll be sure to get back to you as soon as I can. Also, guys, I really want to ask you, have you been provided a customized workout program by a specialist who really understands your injuries or problems? Because we find that this is insanely pivotal and instrumental to helping people continue to avoid pain, not just during the next 6 weeks or 10 weeks when we're treating you, but we're really trying to help people for a lifetime. Step 1 would really be the most important rehabilitative exercises targeting your weakest muscles. So if that is your supraspinatus muscle, then we need an exercise that really targets that. If that's your infraspinatus or your delts, we need exercises that target your primary, most weakest spots. After that, your step 2, let's progress. Let's kind of dig a little bit deeper and think a little bit wider, right? If we start even getting into some back strengthening, some chest strengthening, some core strengthening. The shoulder is just one piece of the puzzle in the upper quarters. We need to start thinking a little bit more holistically and providing a supportive environment for that shoulder. Step 3, we've got really a true case of a whole body approach. We've got much more mobility going on. I've helped people with shoulders by hip flexors. Think about that for a second. The hip flexor will pull on your spine, which makes the spine tight. You can't reach up as high. We are so connected. I think we all probably know that cliche and believe it, because it's truer than ever, it seems. We'll also start to increase weight a little bit more intensity on your workout program. And then we want to make sure that you guys can truly master this on your own, because we're not a dependent clinic or anything like that. We want you to really master a workout program that's right for your body, that's right for you, where you're at right now. And then you can continue to progress that. We might check in with you every now and then, but we truly want you to develop that confidence that you can do everything on your own. This is kind of what our programs look like, just to kind of give you an idea. We've got the name of the exercise here. We'll have the kind of frequency. I think frequency matters, right? How much weight you're doing matters. How many sets and reps and your rest breaks in between each set matter. And they shouldn't just all be 3 times 15 for a minute or whatever the heck it is. It needs to be responsive depending on the exercise we're doing and why we're doing that exercise. We do tend to end up splitting up the workout, whether it's into a 3-day program, a 4-day program, or what have you. And a lot of times we'll see, you'll see this video link here. A lot of times we'll record you in the gym doing the exercises, making sure that you can do them appropriately. That's, again, right for you, because I've noticed a lot of people need different cues when they're doing these exercises. So whatever cue makes most sense to you is what you need. So that's just an example of what we look for, and we do send you that program, and you could watch it on your phone when you're doing a workout. So we've tended to find that that's been really helpful. Okay, kind of coming into a finishing close here. I want to ask you a personal question right now. What's next for you? You've really got, in my opinion, 3 options. You can continue what you're doing. You can keep looking it up, do it yourself, videos and techniques on YouTube. If you give us the opportunity, show you the way. So right now to you, if anything I have said today resonates with you and you'd like our help, I think a prime assessment would be absolutely perfect for you. So just to kind of give an idea of what it is and how we get started when we help those with shoulder pain, it's a full 1-hour-long assessment. We want to understand your story, man. Oh my gosh, everyone has such a different story. It's actually quite amazing. It's actually kind of a fun for me just to hear and listen to what you guys have been through and what you've been through. I want to understand what your story is. Maybe you haven't been listened to or even thrown around the web of healthcare, and no one's really addressed or worked on you like the way you know you need it. That's where I have an opportunity. We have an opportunity to listen to you. The postural examination is key, not just static but dynamic. Functional examination, if you're able to do it, I want to see you do push-ups. I want to see you do rows. I want to I want to see you kind of have to pick up something heavy off the floor if possible. I want to see that in action. I want to record it and I want to analyze it. Strength assessment. We want to isolate each muscle around that shoulder. We don't want to leave anything up to chance. Also, I want to assess your joint. I would have to tell you, about 9 out of 10 times, people think they have really bad arthritis in the shoulder and they think it's a joint, and it's not. It's the muscles or tendons coming around from it. The joint actually usually feels really good, even with shoulder pain. We want to analyze your functional movement. We want to provide you that video analysis of exactly what's going on. I want to tell you what I honestly think your diagnosis is. Is it that bursitis? Is it a rotator cuff tear, right? Is it a bicep tendonitis? We have a really good opportunity to actually tell you what we think it is clinically. Even if you haven't had an MRI, we can come really close to it a lot of times. I think you'll find it quite surprising how close we can come just with a clinical examination. We need to get into a stretching and strengthening program that's customized right for you. And let's get you writing notes, right? How are you sleeping? How are you holding on that bag? What are you currently doing? Maybe for your tennis or golf or your workout program or kickboxing, whatever it is. I want to see what that looks like. We need to analyze what you're already doing and start to break that down into your do's and don'ts. That's right for you. And we want to provide you a customized plan. All right, so to be honest, since you joined us on this kind of educational workshop, typically we offer these at a $239 value. I've opened up 10 spots. Those of you that are here right now, I'd like to offer you that free prime assessment because you've taken the time out of your day to be with us here tonight to kind of go through this, and looks like we still have over 300 people here. Fantastic. So you might want to grab this fast if this is something that you feel like is right for you. We want this to be only for those that are really serious about taking care of this. So you can click on that offer right there. You'll see it kind of in the chat box right now. That should pop up. It'll take you to a page where you could provide us some initial information, and we can kind of get started with that. While you're contemplating that over, this was just an amazing success story with her. And look at this key line that she had said. I still can't believe that I have not had to go to my orthopedic doctor for the usual 6-month steroid injections. And you can see this is a pretty lengthy review because it really meant so much to her. She had dealt with, look at this, a torn rotator cuff and osteoarthritis that remained constant. We were able to get her back to working out. That was really what she was most interested in. She wanted to get back to living her life. She wanted to avoid the corticosteroids. She didn't want to do any more damage. She wanted to avoid surgery. And we were able to knock that out of the park for her. She's still doing great, still doing her exercises. We've had to check in every now and then to progress her exercises. But that's what it's really all about. You know what? We had fun working together. We need to be able to laugh in times of pain. Life's too short to always be miserable and in pain. So I think that's half of it. So, ladies and gentlemen, thank you so much for being here tonight. I really hope a lot of this resonated with you and made sense. I'll give you just a couple last seconds to click on that if you need to, because otherwise it will be closed and only available for 10 people. If you guys need anything else, you guys can just go to our website at www.primemovement.com and would be happy to kind of take care of you in that way too. So thank you again. Have a great rest of your night. Thank you for being here. Take care.